Welcome to today's webinar, The Costly Consequence of Being Socially and Behaviorally Ready by Kindergarten, brought to you by NCSL. It's now my pleasure to turn the floor over to Robin Lipkowitz. The floor is yours.
Good morning or good afternoon, depending on what part of the country you're calling in from. My name is Robin Lipkowitz, and I'm with the Early Care and Education Project at NCSL, and I want to thank everyone for being on the webinar call today, The Costly Consequences of Not Being Socially and Behaviorally Ready by Kindergarten. Today we have approximately 30 states on the webinar. I'm also joined on the line by Julie Poppy and Allison May, both with NCSL's Early Care and Education Program. I also want to give a special thanks to the Early Learning Fellows listening to today's call. We have a really interesting webinar set up for you, and I think the information is really timely in terms of the educational gaps you're experiencing in your states. Research suggests that social-emotional skills are significantly associated with children's academic success and productivity in the classroom. Kindergarten teachers are quick to agree that students that arrive to kindergarten with the skills to follow directions, get along with others, and manage their emotions, those skills are more important to a high-functioning learning classroom than if children come in knowing their alphabet or can count to 20. With strong social-emotional skills, children can easily learn these academic skills, but without them, children can face serious academic challenges. Today's webinar will examine the findings from a new study from researchers at Johns Hopkins University in collaboration with the Baltimore Education Research Consortium. The costly consequences of not being socially and behaviorally ready by kindergarten, along with some areas to influence policy to support children's emotional and behavioral skills. You can find the report in the library on your screen right now for download. Then we'll hear from two state experts from Colorado who will share what the state is doing to support social-emotional development in all settings where children learn and grow. They'll also discuss some innovative policy options that you can consider in your state. We know that some of you may be participating only via phone and not on the webinar platform, and we appreciate your ability to join and listen in. An archived copy of this webinar will be available and posted to the NCSL website shortly. Once posted, Allison will send an email out alerting you to the availability of the archived copy. For our current 5th cohort of Early Learning Fellows, this webinar culminates your time as a current fellow, and you will now become a member of the alumni group. As an alumni, NCSL staff are still here to assist you and your state as you think about policy options for children and families. As an alumni, you will also be added to our alumni listserv and will continue to receive pertinent information and timely invitations. As an alum, you are joining a network of close to 140 past NCSL Early Learning Fellows. Our goal for the next hour is to make the presentation as interactive as possible. Should you have a question, please note that you can type them at any time in the chat box that you see on your computer screen. We'll aim to answer as many questions as possible during and at the conclusion of the presentation, giving questions from our fellows top priority. If all questions are not answered, we will aim to answer them at the conclusion and send out answers via email. So before I turn the webinar over to our first presenters, Deborah Gross and Amie Bettencourt, I want to give you just a little bit of information about our speakers. We have a packed hour, so in consideration of the time, I'm just going to be very, very brief. The full bios are available on the screen in front of you and obviously on the download as well. So first we have Deborah Gross, is a Leonard and Helen Stillman Endowed Professor in Psychiatric and Mental Health Nursing, and is best known for her work in promoting positive parent-child relationships and preventing behavior problems in preschool children from low-income neighborhoods. Dr. Amie Bettencourt is the CHIP Project Director and at the Fund for Educational Excellence, adjunct faculty member at Johns Hopkins School of Public Health and Johns Hopkins School of Nursing, and is an affiliate faculty member of the Baltimore Education Research Consortium. We have Molly Yost, who is the Launch Together Technical Assistant and Policy Manager at Early Milestones, Colorado. And lastly, Noelle House is an Irwin Harris Infant Mental Health Fellow graduate and currently is the Young Child Wellness Coordinator for the Project Launch Weld Systems Navigation Project in Weld County. And with that, I'm going to turn the call over to Deborah and Amie.
Thank you for having us, inviting us to do this. So the There's been an important shift in the most common types of chronic problems affecting children in the United States. As shown in this slide, the top 5 chronic pediatric conditions are now all related to social, emotional, developmental, and behavior problems. Asthma ranks 6th among the most common chronic health problems in children. It should also be noted that these social, emotional, and behavior problems start early and are more than twice as likely to occur among children living in poverty. How does poverty harm behavior and learning? Well, one way is the increased likelihood that the children in poverty will be exposed to high levels of environmental stress. Referred to as adverse childhood experiences, or ACEs, children living in poverty are more likely to be exposed to a range of ACEs such as violence, maltreatment, parental mental health problems, and parent loss. And many children are exposed to multiple ACEs, not just 1 or 2 stressors. This pileup of traumas and adversities makes it difficult for students to pay attention, manage emotions, and process and remember information. In fact, children exposed to 2 or more ACEs are nearly 3 times more likely to be retained in grade and about twice as likely to be diagnosed with ADHD or other behavior problems. In Baltimore City, where over 85% of public school children live in poverty, nearly a third of children are exposed to 2 or more ACEs. A recent survey of Baltimore high school students found that 43% of students witnessed violence at least weekly, and 39% had known someone killed before reaching adulthood. This is a very different childhood than one would expect, especially given that Maryland is one of the most affluent states in the country. Elijah Anderson has referred to this as the risk gap, not the achievement gap. This is an important distinction. An achievement gap focuses all of our attention on schools, teachers, and inadequacies in our education policies. Framing the problem as a risk gap focuses our attention on neighborhoods, health, and urban policies. One example of this risk gap is the number of young children entering kindergarten without the social and behavioral skills needed to learn. In 2015, over half of kindergartners entering Baltimore City public schools were not meeting benchmarks for social behavioral readiness. These are skills we typically expect children to acquire before they enter school in the context of a supportive, consistent, and nurturing home environment. So what are these social behavioral skills? They're sometimes actually referred to as non-cognitive skills. And there are 3 primary skill areas that are linked to social behavioral readiness. They are social information processing skills, executive functioning skills, and emotion regulation skills. And I'm going to briefly describe each of these in the following slides. So social information processing describes an unconscious series of steps involved in how we selectively attend to behaviors and interactions in our environment, how we assess the meaning and motivations behind those behaviors or intentions or interactions, and how we subsequently respond to that behavior. So children as young as 3 years old can differentiate emotions such as sad, happy, anger, hurt, and fear. They also typically have a simple understanding of motivations and can distinguish between intention and accidental behavior. This enables them to encode and appropriately respond to their own and other people's emotions. So for example, a child who sees a classmate crying may realize the child is feeling sad and may try to comfort that child. However, some children struggle with social information processing and may routinely ascribe hostile intentions to others when none were intended. For example, a child accidentally bumps into another child in the hallway, and that child quickly assumes it was an act of aggression or disrespect, triggering an angry and aggressive response. Executive functioning describes the brain's ability to process information in a way that enables a person to manage, coordinate, and integrate information. It includes several interrelated functions essential for learning, such as attending to tasks, shifting attention in response to expectations, inhibiting socially inappropriate responses, and processing, remembering, and using information. Executive functioning has been described as the brain's air traffic control system. Its development begins as early as the first year of life and continues through adulthood. In preschool, children use executive functioning skills to do things like listen to, process, recall, and use information, follow classroom rules and routines, delay gratification, and stop one activity in order to start another. Finally, emotion regulation skills are important for managing emotions such as frustration, anger, and stress. Emotion regulation skills are essential for children to function effectively in a classroom setting. These skills grow significantly during the preschool years, But as most parents and teachers know, young children vary greatly in their abilities to manage frustration, soothe themselves, and work cooperatively with other children. As you've probably figured out by now, social information processing, executive functioning, and emotion regulation skills are all highly interrelated. A child who can appropriately assess their social environment, for example, shift their attention away from unpleasant situations and refocus their attention to something that's calming or more gratifying, will fare much better in a busy classroom setting environment than those who struggle with these skills. With this background in mind, I'm going to turn the presentation over to Amie Bettencourt, who will walk us through a study we conducted to understand how problems with social behavioral readiness can affect children's later academic success.
Thanks, Debbie. So we know that children who enter kindergarten not school ready have more difficulties catching up, and we know that economic disadvantage contributes substantially to gaps in school readiness. We typically think of these types of readiness skills as those tied to language development, literacy, and knowing your numbers. This body of research has been an important impetus behind the huge investments we've made in Head Start, pre-kindergarten education, and other enrichment programs. What we don't know is whether there is a unique contribution of social behavioral readiness to academic outcomes. If social behavioral readiness confers its own separate effect on academic outcomes, and those are skills learned in the context of a parenting relationship, we may need to rethink or expand our strategies for closing the achievement gap. In the current study, we examine the impact of not being socially and behaviorally ready for kindergarten on 3 costly academic outcomes: being retained in grade, receiving services and supports through an individualized education plan or 504 plan, and being suspended or expelled from school at least once by 3rd grade. Our goal is to use this information to inform early intervention efforts for strengthening children's social behavioral skills prior to and during the transition to kindergarten. This study took advantage of administrative data on 2 cohorts of students enrolled in Baltimore City public schools. Each of the cohorts included over 6,000 students, but for the purpose of this study, we only included students who had kindergarten readiness scores, since that was our primary focus area, and students that remained in the school district consistently up to 4th grade, so we could accurately determine grade retention. Just over 50% of students in each cohort were male, over 85% were African American, between 80 and 90% qualified for the free and reduced price meals program, and between 80 and 83% had attended some type of formal preschool program prior to kindergarten. Our primary measure was the Maryland Model for School Readiness, which is a portfolio-based assessment that assesses 7 different domains of kindergarten readiness: language and literacy, mathematics, scientific thinking, social studies, physical development, the arts, and personal and social development, which is our primary interest in this study. We'll talk about and compare students who are fully ready to students who are not ready, which could be one of 2 categories, developing or approaching. Just want to note that since there are many things that contribute to social behavioral readiness in kindergarten as well as to our outcomes, we controlled for a list of sort of child characteristics as well as school level differences in all of our analyses. Data were analyzed separately for each of the cohorts because we wanted to see, can we get the same results across the 2 different cohorts of students. And we also examined 2 different outcomes to see first what the immediate impact of not being socially and behaviorally ready is on kindergarten outcomes, and also what the impact of social behavioral readiness is by the time children reach 4th grade. First, I want to point out some basic differences in terms of social behavioral readiness. Children who were not socially behaviorally ready for school were more likely to be male, to come from low-income families, to have not attended some type of formal preschool, and to be chronically absent from school and kindergarten. Within our analyses, once we conducted a multi-level logistic regression, controlling for all the things that I mentioned before, as well as the 6 domains of readiness. And we find that students who were identified as not socially behaviorally ready in kindergarten were 80% more likely to be retained at the end of kindergarten, and between 40 and 60% more likely to be retained at some point during the next 3 years of school. These same students who were not socially and behaviorally ready were not more likely to receive services and supports through an IEP or 504 plan in kindergarten. However, they were 50 to 80% more likely to receive such services and supports during the next 3 years of school. We also examined the outcome of suspensions and expulsions, and we found that for students who were not socially and behaviorally ready in kindergarten, they were up to 7 times more likely to be suspended or expelled at least once in kindergarten, and up to 2.7 times more likely to be suspended or expelled at least once during the next 3 years of school. Finally, I want to talk about our findings related to gender. As you may recall from what I mentioned earlier, boys were more often identified as not socially and behaviorally ready. I want to call your attention to some other important findings. Within the context of our multi-level logistic regression models, after taking into account other student characteristics and all domains of readiness, we consistently found that boys were significantly more likely to experience all 3 of our outcomes in kindergarten and during the next 3 years of school. To understand the impact of these outcomes for children, families, schools, and society, we decided to look at some of the estimated costs associated with not being socially and behaviorally ready for school. The cost of grade retention is essentially the cost of 1 year of educating a student. According to USDE, that cost is about $11,000 per student per repeated school year. The cost of special education or additional services and supports provided under a 504 plan varies by the need and type of disability. However, it has been estimated that on average, special education costs districts an additional $10,000 per student per year of services. Although the costs of student suspensions and expulsions are not available, we know that it incurs substantial costs related to school staff time to address behavioral incidents, lost school funding due to student absences, and lost parent wages due to missed work or paying others to supervise their child while suspended or expelled. We have not included the cost of school dropout, juvenile justice involvement, and decreased participation in the workforce, all of which are more likely to occur among children who have experienced the early academic difficulties that we examined in this study. I want to return to one of our original points, that social behavioral skills develop long before children enter school in the context of the family. Although I believe there is wide consensus that parents are central to children's academic and general well-being, we really don't have a clear vision for how to effectively support parents in school settings. For example, there are a number of evidence-based parenting skills programs shown to strengthen parenting skills and capacities and improve children's social, emotional, and academic outcomes. However, we do not have a clear policy, strategy, or payment mechanism for building parenting capacities in the school setting. Yet this is where it's having a devastating impact on children. Moreover, schools are a natural, non-stigmatizing setting where we want parents to be actively engaged. I also want to highlight the impact this has on teachers. When teachers are unable to manage student behavior in the classroom, learning for all students is diminished as teachers spend more instructional time on behavior management. It can be pretty daunting for teachers when over half the students in a classroom are struggling to follow directions, manage their emotions, organize and complete tasks, and get along with others. Meanwhile, the teacher is accountable for helping their students achieve a more rigorous standard in reading and math than prior generations of kindergarten teachers. Not surprisingly, teachers working in urban school settings serving a high proportion of low-income families can become demoralized. Before we conclude, I think it's important to highlight some important study limitations. First, the data analyzed were only for students who took the MMSR and remained in the school system through 4th grade. As a result, certain groups were more likely to be excluded. Specifically, those excluded were more likely to be white and chronically absent, and less likely to be African American, low income, or have attended formal preschool. There's also a number of important factors that we did not measure or control for because they weren't available to us. Those include things like parent education level, mental health, and neighborhood stress. These might have been important factors, more important factors than just income. Finally, the MMSR social behavioral ratings relied heavily on teachers' reports of student behavior. We know from numerous studies that teachers and other adults can hold biased perceptions of behaviors that could affect ratings, particularly with regard to African American male students. The study results are consistent with a number of other studies focusing on and highlighting the significant vulnerability of boys growing up in poverty and that poverty's effects on learning start early. The study extends prior work by showing the unique contribution of social behavioral readiness to 3 costly academic outcomes: the likelihood of being retained in grade, receiving additional service and support through an IEP or 504 plan, and being suspended or expelled from school. We want to point out that there are programs that can effectively support young children's social and behavioral readiness, but they do cost money. But as the data presented here suggests, the cost of not addressing the growing problem of children entering kindergarten without a strong social and behavioral foundation may be far greater. Finally, we highlight here the 4 main categories of evidence-based programs that have been shown to have a positive effect on children's social behavioral skill development. These include teacher programs that support teachers in effectively managing behavioral issues in the classroom and providing consultation to teachers, mental health consultation that offers family-focused services and consultation with staff in handling individual cases when children are having emotional and behavioral problems, social skills training for children to support social information processing skills, emotion regulation, and social problem solving, and parenting programs for strengthening parenting capacities, helping them support their children's social behavioral readiness for school, and building relationships with parents. Depending on the needs of the student population, the strongest effects are likely to be felt when more than one type of program is used because they target different but related aspects of social behavioral readiness. I'm going to turn it back over to Debbie to talk about an initiative we are doing in Baltimore City schools with parents.
So I don't think it would be fair if we just left you with a problem and not some examples of solutions to address the problem. In 2014, Amie and I were funded to implement an evidence-based parenting program in Baltimore City schools pre-K called the CHIP Project. The purpose of the CHIP Project was to work with schools in engaging parents in a 12-session program designed to strengthen parenting, improve children's social and behavioral readiness for kindergarten, and improve their academic outcomes. Although there are many evidence-based parenting programs that are available, we used the Chicago Parent Program, which was originally designed to address the needs of African American and Latino parents raising young children in low-income urban communities. We focused this work on parents of students in pre-K primarily for 2 reasons. First, it's an important transition period for families and therefore a great opportunity for schools to engage parents. And second, our research design included examining the impact of the CHIP project on students' kindergarten readiness scores, which would be collected on all students the following year. Also, to boost parent participation, we used a conditional cash transfer program. We just completed our 2nd year of the CHIP project, so our results here are preliminary. So far, 213 parents of pre-K students in 9 schools have enrolled in the CHIP project. Almost all of the parents are African American or Latino, and we offer the program in English or Spanish since most of the Latino families are immigrant and do not speak English. I think the most important change we've seen thus far is the improvement in children's behavior. Although we do not specifically recruit parents of children with behavior problems are common. At baseline, over 40% of the children in the CHIP project had behavior problems in the clinical range. And this is the range in which scores are 1 standard deviation or higher than the population norm. But after the program, we found a 48% drop in the number of children with behavior problems in the clinical range. Most of the parents also reported that the concerns they had about their children's behavior were now much better than before they started the program. 69% reported that attending the program helped them a lot with relationships other than with their child. And 3/4 of the parents reported feeling much more confident talking to the child's teacher about their child's behavior. And most importantly to us, 96% reported that participating in these types of programs made them feel valued by their child's school. I also want to say a few things about the conditional cash transfer program we used. Participation rates in these programs, as in many prevention programs, tend to be extremely low. It's one of the main reasons schools often give up trying to engage parents and instead focus on strengthening the school workforce, which is a captive audience. So we knew from the beginning that if we couldn't get parents to come, the project would be doomed. So when parents enrolled in the CHIP project, they received a bank debit card. We explained that every time they attended the 2-hour parent group sessions, $15 would be loaded instantly on their debit card. If they did the weekly skill building practice assignments, they received an additional $5. The maximum amount that could be earned was $230 for the entire program. In enrollment, we asked parents to complete a survey of what motivated them to sign up for the CHIP project. And this survey included a list of 13 different possible reasons for signing up, including the extra money. Turns out that although 73% had checked off the extra money as one of the motivators for signing up, 96% identified wanting to be a better parent or wanting help with their child as the most important motivation for signing up. And importantly, 80% of parents who enrolled in the CHIP project actually attended the program, and average attendance was about 2/3 of the sessions, about 8 out of the 12 sessions, which is terrific. And the quality of their participation was high. We wanted to make sure the parents weren't just coming for the money, and so we had group leaders used a measure of parent engagement, and we found that the parent engagement scores were extremely high. It's important to note now that every school involved in this project as we enter our last year has invested in continuing the parent program once the funding ends in the next academic year. And we're working with Baltimore City School of Leadership to figure out ways we can sustain the program through a combination of Title I funds and other public and private sources. Sustaining the program also means institutionalizing it in schools that have existing early childhood initiatives. In Maryland, we're fortunate to have a growing number of pre-K programs, but we also have something called Judy Centers. Judy Centers are the brainchild of Congressman Steny Hoyer. They were written into Maryland law in May of 2000, and Judy Centers are designed to provide a central location for early childhood education programs and support services for parents and children birth to kindergarten. They are funded through a combination of state, federal, private, and local funding sources, and they are monitored and accredited. Currently, there are 52 Judy Centers in the state of Maryland and 13 alone in Baltimore City, though there are more planned for the coming year. All are located in or near Title I schools. And since one of the goals of the Judy Centers is to strengthen parenting capacities, they have become a natural home for the CHIP project. This is our final slide, and I just want to summarize the key take-home points before we go on. And the first is that growing up in urban poverty is having a devastating effect on young children's social and behavioral readiness to learn. Also, the social behavior readiness skills are required before children enter school in the context of a strong parenting relationship. 3, although preschool enrichment programs and teacher development programs are important, they are not enough. We need to invest more in strengthening parenting capacities. 4, school-based parenting programs can benefit families if they are evidence-based, strength-based, and they're relevant to the issues that parents face when raising young children in urban poverty. And finally, Judy Centers, which were written into state law, supported by public and private dollars, and designed to support parents and families, are an innovative and replicable strategy for strengthening families in the first 5 years of life. Thank you. Can we open up to questions now?
So, again, if you have any questions, you can type them in the box. You have a chat box off to the left-hand side. And we have time to maybe take 1 or 2, and then we'll come back at the end for any additional questions. Okay, so maybe this is a lot of information to think about,
I see one about what was the total cost?
Yeah.
So the total cost for running a Judy Center is, the best estimate I have is $360,000 a year, and that's essentially to pay for the staff, three staff, a coordinator, a family service coordinator, and a mental health consultant in many cases. But then what happens is they coordinate with other existing programs that are in the area.
And we can also get you, for those that are interested, more information, more detailed information about the Judy Centers and how they're funded. Do we have any other questions before moving on? Okay, well now we're going to move on to our second presentation that'll discuss steps that Colorado is taking to address the issues that have come up, that were raised in the previous presentation and part of the research that was done. So Colorado is taking certain specific steps to address supporting social, emotional, and behavioral health for children and their families. So now, Molly, Noelle, the platform's yours.
Great. Thank you so much, Debbie and Amy, and thank you, Robin, for this opportunity. Noelle and I are really excited to present a case study on how Colorado is leveraging investments and prevention models to improve behavioral, developmental, and school readiness outcomes for young children before they even enter the kindergarten door. And so we hope to really contextualize the findings from the report that you just heard about, look at how to mitigate those costly consequences by supporting social emotional development in all settings where children learn and grow. So in the home, in primary care, in preschool, in human services settings, and also highlight policy opportunities and innovative solutions through public and private efforts that are really closing the gap between what we know through this research and what we're actually doing about it. So let's start by better understanding these challenges. And while data trends confirm strides in supporting healthy development, and we need to celebrate those successes, statistics also point to significant barriers to behavioral health that warrant a call to action. So we see that preschool expulsion is something that has gained a lot of traction in Colorado. Children are removed from child care settings at about 3 times the rate as those children in K-12. And this raises very important systemic and social issues around this and how this is disproportionately impacting children of color and boys in particular, teacher stress and mental health and well-being. The next statistic you see, approximately 17% of children under age 5 experience some kind of problem, yet less than half of these issues are detected before entering school. And this just shows that without adequate early identification, children will really continue to struggle in school from the start. The next statistic you see on your screen about parents that have concerns about their children's emotions and behavior, but only a fraction of these parents are actually getting mental health supports. I think this points to our growing and changing population and how we need to consider how parents and caregivers and children are accessing social emotional supports, and also recognizing the need for whole family care and that children really do function within the context of their caregiving environments and their family. And then the fourth statistic about when mental illness begins to emerge, I think this just emphasizes the importance of the continuum of health promotion, prevention, early identification, and intervention in settings where children are seen by professionals that are able to screen, refer, and coordinate mental health care for young children. And so if we unpack some of these root barriers across access and now we have a system that is individually focused, a very disease treatment approach to healthcare delivery that doesn't work for the child population. There's a lack of existing infrastructure to support a robust screening and referral system. There's lack of coordination and alignment across primary care providers and mental health providers. Additional resources are definitely needed to help children and families in crisis or with severe mental health needs. And underlying all of this, I think, is stigma, which makes it even more difficult for families to access services. On the financing side, in this fee-for-service healthcare financing model, that pays providers for rendering specific services for diagnosed conditions. And this current system doesn't work well for providing promotion and prevention services to children who may not have yet a diagnosable condition. And lastly, workforce development and systems capacity. So we definitely have inadequate workforce and systems capacity to provide the services that are needed. Practice change and workforce development are very difficult and often require incentives and additional supports. And mental health professionals working in primary care and other early childhood settings need specific training and education necessary to promote child and family mental health and well-being. So we'll begin to address, or we'll share how we're beginning to address these barriers and how Colorado is seeking solutions to these issues through state-level leadership and vision, public-private enthusiasm and investment, and local innovation that is informing policy change. So what you see here on your screen is Colorado's early childhood framework, and this is our North Star for early childhood systems building, which has recently been updated to reflect new research and investments. This has been endorsed by our governor-appointed Early Childhood Leadership Commission, our state's Early Childhood Advisory Council, and this vision is really embraced by state government and leadership, foundations, local leaders across the state, really a very broad range of stakeholders. And I know this is too small to read, but a few important changes in this updated version that I'd like to point out. That this now covers prenatal through age 8 instead of birth to 8. Research around expectant mothers who struggle with mental health issues, toxic stress, and adverse experiences and how that impacts fetal development is very important. So we thought it was critical to start this conversation at prenatal. You'll see that the health and well-being domain in the middle of your screen was previously separated out between mental health and physical health, but they have been combined here to show how important the integration of these two strategies are in supporting whole child development. And lastly, on the right-hand side where you see those concentric circles, really highlighting that children really do develop within the context of family, caregivers, environments, and local and state systems. So this is kind of our North Star guiding a lot of investments and work in Colorado. Next, this is our a snapshot of our state's mental health state plan that was put forth by the Office of Early Childhood in our Department of Human Services. You can see that it's very much aligned with the Early Childhood Colorado framework and puts forth strategic priorities around sustainable financing, coordination, and workforce capacity, and that really look at addressing some of those systemic barriers that were mentioned a couple of slides ago. So now we're going to focus on highlighting some of the turning points and public and private investments that kind of help set the stage for meaningful change. And while I won't be walking through every item you see on this timeline, hopefully you can look at some of these and see if you have similar efforts or strategies in your state. So first I'd like to call out SAMHSA project launch in 2008. So this is a federal initiative administered under the Substance Abuse and Mental Health Services Administration with the goal of all children entering school with the social, emotional, cognitive, and physical skills they need to succeed. There are over 55 awards to states, communities, and tribes that are implementing a core set of 5 prevention and promotion strategies and really infusing knowledge about child health and development through evidence-based practices and systems coordination. And you'll hear more from Noelle in Weld County, who's the recipient of one of these awards in 2010. And she will be talking more about what those strategies look like in action. The next item I'd like to call out is the establishment of an early childhood funders network in 2013. And this really reflects a lot of momentum and energy from the foundation community, especially after an early childhood mental health environmental scan was completed. And one of these funders in this network really was the champion and held the vision for what a privately funded expansion of project launch, of the federal project launch, could look like. So between Weld County's award and another federal project launch award in Colorado in 2014, that really set the stage to build and expand on these strategies and efforts across the state. And that leads me to 2015, where you'll see Launch Together was started. And as I said, this was very much inspired by the federal Project Launch initiative. Launch Together is an $11.2 million privately funded initiative that has supported 7 very different communities across the state through planning. And of those 7, 4 are receiving 4-year implementation awards to put their strategic vision into action. And I think just to conclude on this slide that this didn't happen overnight, this kind of investment and will building. So there are many turning points that I haven't gone into detail here, especially the state innovation model and the hiring of a early childhood mental health state director that's actually funded through private and public dollars. And happy to talk offline about any of these other milestones that you see. So if this has felt very theoretical, don't worry. We're going to turn to the project launch framework and the 5 key strategies in this graphic, which we are also using to guide the privately funded Launch Together initiative. So very quickly, we're looking at screening and assessment in child-serving settings, the integration of behavioral health into primary care, mental health consultation in early care and education settings, enhanced home visitation, and family strengthening and parent support programs. And we are learning so much from Noelle in Weld County and other communities across the state that are helping to inform broader policy, financing, infrastructure, workforce issues. And Noelle will be providing examples of what these strategies look like in action, and would just encourage you to think about these strategies that you have in place or may not have in place as you look to create a more cohesive and seamless early childhood mental health system. And so with that, I'll kick it over to Noelle.
Thanks, Molly. So as a Project Launch grantee, we were responsible for addressing these 5 strategies that Molly mentioned. And so the following slides are just a few examples of the activities that we put into place that we planned and administered to address each of these strategies. All of the activities were addressed through workforce development, including training and mental health consultation and mentoring. This first slide that you see is an example of the screening and assessment strategy that we addressed. And we did this, we had multiple partners. I just want to preface these slides with, we had multiple partners across domains. So we were working with primary care, Department of Human Services. We were working with home visiting programs. I did some question about that, and I will address that. Our behavioral health, mental health, behavioral health program. And so across all of those partners, there were multiple activities that we did across those partners, and one of them was screening and assessment. So with all the partners that we did work with, we did have them screening in some capacity as it fit within the context of their organization and the purposes and their goals. But for this particular example, we have Sunrise Community Health Center, which is our federally funded health clinic, and they have 4 clinics in the area. And when we worked with them to kind of develop a joint goal, we identified that they had a lack of consistent standardized developmental screening practices. And more specifically, there is a recommendation from the American Academy of Pediatricians, which is the periodicity schedule recommended screens, and they were not following that. In fact, we found that most of the providers that we worked with in the area do not follow that schedule, and there's multiple reasons for that. The largest of being that there is not a reimbursement. There's not a reimbursement schedule that matches the recommendations. And so with the federally funded health clinic, because they already receive an enhanced rate, we were able to put into place a screening protocol in which children that were coming in for their well-child visits were getting not only developmental screens, but social-emotional screens, which is a recommendation of the periodicity schedule that a child get social, emotional, and behavioral screens from birth through 18. But those screens currently are not reimbursable at all. So we worked really hard with them to get an office process in place, the screens in place. We didn't have to worry about reimbursement with them because they were already enhanced. The screening tools were done using electronic tablets. They are just completing the merge with their electronic medical record, which is pretty exciting. That's been several years in the making. And now they're able to refer on to community partners for early intervention. I will also add, and it's not on any of these slides, but one of our partners, being early intervention, did experience a 100% increase in referrals once the screening protocol got up and going. So it is something to keep in mind in terms of creating capacity within your community to address those case findings. I'm going to go to the next screen, which is kind of similar, but this slide is highlighting really what we did around behavioral health in primary care. So this was a private pediatrician that chose to participate with us, and not only did we implement the screening tools at Everywell Child Tech, but we implemented mental health consultation in primary care setting. So this is whereas in Sunrise, they already had behavioral health is already integrated at their clinics. This particular clinic, which served about 90% Medicaid children, did not have primary care mental health consultation available at the time that we started. The other unique challenge that came up for them is that as a private provider, they are billing for each screen that they do, and this is where we found the mismatch of reimbursement rates for the recommended screening. And so in our state, the screening reimbursement, we only receive, I think it's 3 developmental screens up to age 3, 2 screens to age 5, but between the ages of 5 and 10, there was no reimbursement for any screening. And from the ages of 10 to 18, only 1 screen was allowed, and that is a depression screen. So there's an incredible gap between what the recommendations are related to screening and what is being reimbursed, and so therefore the implications for private physicians is that they are not completing the screen. So I'm going to move to the next slide, which is an example of mental health consultation. And in fact, even though I have HIPPY listed here, we did mental health consultation across every single one of our partners, and each partner, it presented, unique challenges and strengths and opportunities with mental health consultation. In the mental health consultation, we've just finished documenting the infant mental health consultation model that we developed and used throughout the last 5 years, and so that will be available shortly. But what made our project unique was most people do mental health, or most research is done with mental health consultation in either primary care or early care and education settings. Our mental health consultation was done across all settings, so the child protection and prevention services, home visiting services. So we really did a very comprehensive strategy with mental health consultation. And while home visiting impacts, there was a question earlier about, what about the impact of evidence-based home visiting? while it does positively impact child, parent, and social behavioral readiness, we found that home visitors overall were very ill-equipped to address significant risk factors related to things like domestic violence, substance abuse, trauma, stress, and other mental health challenges, and that the burnout rate, the secondary trauma that home visitors experience is really high. And so our mental health consultation model not only provides mental health consultation to families, but it provides mental health consultation to providers in two different ways. One, to address concerns that they have about an individual or particular family, and two, to address practices in general, so that providers actually increase their professional capacity to address these issues. So with HIPPY, for example, the one thing that we did implement, again, was screening across all of the different home visiting families, but also made available the mental health consultation piece to start connecting these families with behavioral health services. I'm going to go to the next slide, which was our strategy around enhanced home visiting. And even though we addressed HIPPY in the last screen, that was for mental health consultation, I really want to highlight enhanced home visiting examples that these models, these evidence-based home visiting models, have great outcomes. This enhancement piece, though, is the piece that provides the mental health expertise to these models. And we use the example of nurse-family partnership because the nurses in our community were so overwhelmed by the incredible need of the women that they were seeing. And when these women could not be emotionally responsive and ready to support their infants or other children in their home, then the nurses didn't know what to do with that. And the nurses in this particular model, at least in our community, feel like there are so many expectations on them in terms of assessment and all of the different mandates that they have in this model, that requiring them to do the mental health piece really felt like it put them over the edge. And so one of the things that we did with this, with enhanced home visiting, is not only did we provide a mental health consultant to meet with them and staff families and provide consultation around specific topics of mental health, but we also provided reflective supervision for the nurses so that they could process the really difficult situations that they were walking into in the home settings. And I give one example of a nurse that was addressing a mom that had a significant diagnosis of schizophrenia, and this nurse was just having a very difficult time balancing the needs of both the mom and the infant. And because her relationship was with the mom, she was really wanting the mom to succeed. And unfortunately, the infant was really in peril, and it was through reflective supervision that she was finally able to see that the baby was not in a safe situation. But it was a very difficult thing for her to come to because she wanted the mom to succeed so much. And so that's just an example of work with nurse-family partnership and enhanced home visiting. And then our final screen on examples is family strengthening. And this has been an exciting strategy for us. We're using North Range Behavioral Health as our example here, and that's our mental health center for our county. We have a 4,000 square mile county, and so they are charged with, addressing the needs of a lot of folks. And in this case, there were no evidence-based practices at the time that we started Project Launch. They were not using any evidence-based practices in the population of 0 to 8. They primarily were providing individual play therapy for children and not involving caregivers in that process or focusing on relationship practices. And so even though we had this project is very data heavy, and we, again, like Molly said, would be happy to share anything if people have individual questions about some of our activities. We also had some informal things that I was tracking, and one of them being that when you walked into the mental health center 5 years ago, you would see multiple parents sitting in the waiting room waiting while their children were getting individual play therapy services with therapists, and then they would come out after an hour and they'd go home, and the parents, it had not increased the capacity of the parents to support their child's needs. The child developmentally was not able to go home and generalize the skills that they had learned and cope on their own. And so 5 years later, due to all of the evidence-based practices that we have brought in to the agency, I'm pleased to say that we have no parents waiting in the waiting room, that all parents and caregivers, including foster care parents, are now involved in children's therapy from birth to 8. It doesn't matter what the therapy is for. If it's behavioral, if it's a trauma-based therapy, they are participating in that. And so that's been very exciting. It's very difficult for my team at this point to consider doing it in any other way. And so because of that, we are shifting the way that human services, the court system, and foster care and parents view their participation in intervention. On the next slide, the next 3 slides are just overall collective impact kinds of outcomes that I wanted to share. And just particularly this slide so that you can see the bigger picture, but we were able to increase a shared vision, mutual respect, understanding, and trust between all of our partners, and members reported viewing collaboration as in their self-interest, and so that it was motivating for them to collaborate. Our partners developed shared sustainability priority areas in screening and assessment and workforce development, mental health consultation, and replication, which we are now doing with Launch Together at more of a state level. And I also want to say that because of this, another project, we've just received funding for another project in which we will now be providing mental health consultation in the judicial system. So we're really excited about that. And then finally, just a shift in attitude overall and desire to become trauma-informed and family strength-based. So many of our organizations were not seeing or looking at family strengths and really overlooking or really not even able to recognize or see the impact of trauma and stress on young children. And now all are very interested in that in terms of workforce development. They're using those words. They're assessing children. We have a project with our human services right now in which they are screening children that are opened in child protection. They are screening them for trauma. If they come up with a positive screen, they refer all of those children now to our mental health center, and where we're doing full assessments around trauma, and at that point making recommendations about the most appropriate evidence-based trauma intervention.
Noelle, this is Robin at NCSL. Yeah. I'm just going to jump in quickly because we're running out of time. I just want to be conscious of giving the participants an opportunity to ask some questions. So sorry to do that, but if you could just quickly wrap up.
Yeah, the next 2 slides are pretty self-explanatory. So it's the collective impact on provider outcomes, just around their increase in knowledge. And then the next one after that is really more around just our numbers, what we impacted across the last 5 years. So yeah, questions are good.
So we have a few minutes left. If you have some questions, please type them into the chat box, and we will announce them for everybody to hear.
And Robin, this is Molly. While you're waiting for questions, I know we don't have time to walk through it, but I think it's the next slide shows the policy priorities for Colorado, and I won't walk through all of these, but I think this is just a point I thought we're not looking to create a brand new policy agenda, but support and inform existing priorities And I can send you the report, Robin, to share out if that would be helpful for folks.
Okay, that's great. Thank you. Okay, well, if we don't have any questions, I just want to thank so much to our presenters, Deborah Gross, Amie Bettencourt, Molly Yost, and Noelle House for their thoughtful presentations. I want to remind folks that the resources are on the web. An archived copy of this webinar will be available shortly, and email will be sent around once the archived version is available. Your feedback really helps us in creating a meaningful and beneficial program, so we'll be sending around an online survey that will pop up on your computer screen at the conclusion of this webinar. Please take a few moments to complete the evaluation survey because we really do take the feedback seriously and want to hear your thoughts. I'm going to make a little plug for our Capitol Forum coming up in December in Washington, D.C. It'll take place December 6th through 9th. Registration is still open. And finally, please remember that NCSL is here for you. If you have any questions, comments, or feedback, please feel free to email any staff member on the Early Care and Education Project team. We also invite you to email relevant information to your fellow colleagues by using the email distribution list that you see on the screen, which I will put up. So again, thank you all so much, and have a great rest of your day.